Welcome back to Chapter 3, Part 2. We are going to continue to look at some of the primary disorders which have a resulting language disorders. There are more videos in this section. You will not be held responsible for the information on the videos on the quiz or test. Sit back and watch these to increase your understanding of these disorders. Module 3 includes this entire PowerPoint presentation. First, we are going to discuss different motor or sensory deficits which can contribute to communication disorders. Both motor disorders and sensory disorders can put limitations on an individual where it decreases their ability to interact and learn from their environment. We are going to discuss three different disorders in motor and sensory deficits: static encephalopathy, which is also known as cerebral palsy, hearing impairment, and vision impairment. Our first in this category to discuss is CP. The hallmark characteristics of CP is abnormal muscle tone and reflexes. There's something that happens during the birth process or just before or after that results in the child having a neurological damage that affects their motor movement. They have abnormal muscle tone and reflexes. A child with CP can often have tight, spastic tightness of their muscles. They often can't even bend their arms because the muscles are so tight. This is called hypertonia. On the other hand, the individual could have little muscle tone and their limbs are very floppy and weak. This is called hypotonia. Remember that there are muscles in the oral mechanism that will be affected in CP. This can affect their feeding, swallowing, and speech. Now let's talk about Botox. Doctors use Botox with these children. Do you know why? Doctors can use a machine which can sense tight muscles and then they inject Botox into them. The Botox paralyzes the muscles so that it relaxes and the child is able to participate in therapy. Through therapy, the therapists are able to stretch and work on the muscle movements and muscle movement memory. The Botox will wear off after about 6 weeks, but hopefully gains have been made in therapy and a new round of Botox can be used and the therapy can thus continue. There are two videos here for you to watch on children with CP. Pause the PowerPoint and watch the videos. Now we're to auditory impairment. So what happens when a child has a hearing impairment? There is so much variability there. So much difference in if it's a sensory neural loss or whether it's a conductive loss. How old is the individual? Did they have a hearing loss before they started speaking, which we call a prelingual hearing loss, or did they have it after they started speaking, which we call a postlingual hearing loss? Many of us have known people who, as adults or after the age of 10 or 12, who have developed hearing impairment and their speech is not impacted. But for a child who doesn't have speech and has hearing loss, it can have a very significant impact on their ability to learn language. In Texas, we have a mandatory ABR, which is auditory brainstem response testing for children when they are born to help with early identification. This has definitely helped and worked in that early identification. All of the factors on this slide affect the impact of the hearing loss on the individual. Speech sound production errors are very common in those with hearing impairment because they can't hear certain sounds, obviously. This is especially prevalent with those higher frequency sounds like s. They can't hear these sounds, the s, the s, and the f, and the sh. Those are all very hard sounds for them to hear, and if they don't hear them, then obviously they don't produce them. Also, processing inflection and rate of speech is very difficult for individuals when they have a hearing impairment. Vocabulary and semantics is also hard because so much of our vocabulary in the preschool years we learn by listening. And the same thing with the morphosyntactical skills. We learn all the grammar and putting the S on a plural from just listening. If one can't hear the S or the sound at all, then they are not going to know how to make a plural. And with that comes literacy problems. They can't be expected to match sounds to letters if they can't hear the sounds. Let's talk about the impact on the areas of content, form, and use. Individuals are often going to have difficulty with the figurative language in multiple meaning words. They often have difficulty with jokes. They also have difficulty with connected discourse. Think about conversation. It moves fast and it's hard to keep up with. Individuals with hearing loss have a hard time hearing all the sounds in that connected discourse. When individuals with hearing loss produce speech, their intelligibility can be low, their speech rate impacted, they don't use the right stress, and they often leave off those final morphemes like the this in the ed. When it comes to use, you'll see a lot of gestures for communication. Auditory verbal therapy is the preferred intervention for children with a cochlear implant. This type of therapy emphasizes the child learning to listen and the child learning to speak. This is instead of sign language or speech reading. Auditory verbal therapy helps the child discriminate sounds as being important sounds or not important sounds. It even goes into discriminating, is the person's voice or is this an animal sound? And then even with animals, well, is it a cow, a horse, a pig? What animal produced the sound? And when you're getting to the very specific discrimination of sounds, and then, of course, the individual sounds. Think about a mom and a 12-month-old, and the mom hears an airplane fly over, and she says, "Look," and points to the sky, and then she says, "Airplane." Without this interaction, the child has no idea what the sound means, so he might not pay attention to it. It takes interactions like this repeatedly to teach that sounds have meaning. There is a certification program for a therapist to be certified as an AVT therapist. You don't have to be an audiologist or a speech language pathologist to be an AVT therapist, but you also can be. AVT also heavily involves the parents. Besides auditory verbal therapy, the other interventions for individuals with hearing impairment are using manual signs and the total communication method. Total communication uses signs and auditory verbal input. I have conversations with parents and other practitioners quite often on what is the best method for intervention. This is quite the debate. Bottom line, each person is different, and I believe all intervention types we have are good, but a good clinician is going to pick the one that is right for the individual at that moment. The most important thing is that we want to maximize language input. Help this child to learn language and then learn how to use language to be able to communicate and learn from it. Now we're going to discuss vision impairment. Vision impairment can affect one's ability to interact and learn from their environment. Children with visual impairments will usually catch up by school age, but they often need extra help. When teaching a new word, the child has to experience the object in another way because they're not going to see it, of course. So this is usually done tactily. So you will want to use actual objects when teaching vocabulary. So if you want to teach them about a pineapple, bring a real pineapple. Then let them feel the prickly part on the outside and the leaves that are real stiff that are growing up from it. Then cut it and let them feel and smell it and touch the juices and taste it if they want. Now we're going to discuss language disorders associated with prenatal or premature issues. So we're going to be on this slide for quite a bit. Many infants who have had prenatal or prematurity will be classified as failure to thrive. A physically small failure to thrive baby is determined by the infant's head circumference, height, and weight. Also, infants who are delayed in their overall development can be labeled failure to thrive. A child could be born and considered within normal limits for head circumference, height, and weight. Then the child might not gain weight and continue up the developmental trajectory because he cannot suck on a breast or a nipple of a bottle correctly and can't get any food. A lot of times, this is where the speech pathologist will become involved with the child's feeding and swallowing to help the child. Another example of a child not increasing in their development could be because the child has a lingual frenulum under the tongue that is too short or too tight so that the tongue cannot be lifted to suck or help support the nipple while sucking. We can also see feeding and swallowing difficulties because of allergies or gastrointestinal reflux problems. Common disorders which can cause failure to thrive include fetal alcohol syndrome, infants born to mothers with HIV, or infants born to teenage mothers. Now let's talk about infants who are born prematurely. Nowadays, we're saving babies who are born at 24, 25 weeks. Just in case you do not know, a full-time pregnancy is 40 weeks. We think of it as 9 months, but it's actually 40 weeks, which is really 10 months. If a child is born at 36 weeks or earlier, then that is considered premature. There are many problems a premature infant can have. If the child has a breathing tube because he can't breathe on his own, then he's not able to feed and subsequently not able to develop oral motor movements. These oral motor movements are important for further feeding and swallowing skills as well as articulation. He may even develop an aversion to anything close to or in his mouth. So the speech pathologist can be very involved with a child who is premature. The SLP will work in the neonatal intensive care unit or NICU with these premature babies on sucking, feeding, swallowing, oral motor aversions, and then early speech and language development. Lastly, let's discuss the CMV virus, which is a viral disease from the herpes viral strain that results in brain damage. This can be contracted prenatally or postnatally through breastfeeding, blood transfusion, and sexual contact. It can be identified prenatally by a fetal blood sampling. Infants who survive birth have a high rate of mental handicaps, sensory deficits, motor disabilities, and seizure disorders. Now we're going to discuss when infants are exposed to alcohol and drugs prenatally. This next category concerns effects of alcohol and drugs prenatally and postnatally. First, we're going to begin with talking about fetal alcohol syndrome and alcohol-related neurodevelopmental disorder. To be diagnosed with fetal alcohol syndrome, maternal drinking during pregnancy must be documented, and the infant must exhibit all three of these: gross retardation, so the head circumference is small, facial anomalies, and central nervous system deficits. It makes sense that if an infant has insufficient development of head circumference, then brain development will be affected. Research shows that if head circumference is below the 5th percentile, a child is at high risk for developmental disabilities. Children with FAS can also have a short stature, small fingers and toes that are bent or webbed, abnormal palmar creases, hip dislocations, kidney defects, and be at greater risk for failure to thrive. These facial features can include eyes that are slanted, small or squinty short eye slits, droopy eyelids, and eyes that are widespread or crossed. The nose is often flat. They will also have large or malformed ears and mild to moderate hearing loss. Cleft lip and palate are also common. If a child does not exhibit all three, then he will be diagnosed with alcohol-related neurodevelopmental disorder. Both of these disorders so this is diagnosed 3 times as often as FAS, and more often the person has central nervous system dysfunction and not the other two. Both of these disorders will exhibit IQ disorders as well as ADHD and learning problems. As far as drug exposure, if the child is exposed to drugs prenatally, he is at an increased risk for low birth weight, inadequate lung development, poor pulmonary functioning, and can develop childhood asthma. These infants are often very irritable and have increased excitability, and muscle tone is often very tight. Developmentally, they will often have a lower IQ, ADHD, and have delays and deficits in learning language, memory, problem solving, and eye-hand coordination. Our next category of disorders is going to be talking about intellectual disabilities. In the past, the diagnosis of intellectual functioning, or also known as ID, has been called mental retardation and developmental disability. ID is diagnosed when a child has significant limitations in both intellectual functioning and adaptive behavior. So let's first talk about how intellectual functioning is determined, and then we will discuss adaptive behavior. Intellectual functioning is determined by giving an IQ test, which measures one's capacity to learn, not the amount of information they have learned in areas such as short-term memory, analytical thinking, mathematical ability, and spatial recognition. The testing gives a mental age score, which is then divided by chronological age, which is CA, and then multiplied by 10. Since the IQ score is a ratio score, it stays relatively stable despite changes in chronological age. So a score of 70 and below is considered to have ID. 2 to 3% of the population is diagnosed with ID. Here is a chart showing the classification of ID. You can see that 55 to 70 is considered mild. These individuals will often have delayed communication skills and minimal delays in sensory motor areas, but deficits might not be recognized until school age. An IQ of 40 to 55 is moderate ID. These individuals will show delays in talking and communication, but will eventually develop functional language skills. They will often exhibit poor social awareness and fair motor development. The range of 20 to 40 is severe ID and requires custodial care, which means they need to have someone with them at all time. In the preschool years, they will have minimal speech development and continue to have severely limited communication. Individuals with profound ID will have very minimal development of communication, sensory motor integration, and self-help at adaptive skill difficulties. From this chart, you can see that most people function usually in the 55 to 70 IQ range if they have ID. Now we're going to discuss adaptive behavior. Adaptive behavior, plainly put, is one taking care of themselves. It is the ability of an individual to act as independently and responsibly as other people of the same age and cultural background in the areas of conceptual skills, such as language and money concepts, social skills, such as following social rules and the building of self-esteem, and practical skills, eating, dressing, and working skills. Let's think about the adaptive behavior that is expected from someone your age. Since you're in college, I would assume that you can dress yourself, take care of your personal hygiene, and that you can feed yourself and can request things as expected. Now, a child who is 2 years old, I wouldn't expect that from the child, but that child could have appropriate adaptive behaviors for being 2. So to determine the overall intellectual functioning, we are going to want to see what their adaptive functioning is, or their functioning in their world, and then as well as their IQ score. Our next large category is acquired language disorders. Acquired language disorders can occur because of a variety of reasons, including illness such as meningitis, seizures, head trauma, TBI, or stroke. The individual may recover initially with deficits not becoming apparent until the child is older and demands on language and cognitive skills is greater, often when they get to school. Obviously, the more severe the brain damage, the more severe the communication, and all developmental categories will be affected. We will be discussing acquired language disorders in more detail in Chapter 11. The last disorder we're going to discuss is specific language impairment, or SLI. A child with SLI has difficulties with language only and nothing else. They don't have autism, they don't have hearing impairment, and they don't have Down syndrome. They just strictly have a language delay with no known etiology. They come to see you as an SLP and they look perfectly normal, but they just don't know how to talk. They can walk, but they can't talk. These are the children that fall in the 10% of children who did not learn language effortlessly and easily. We see that their nonverbal skills are normal and with the use of a lot of gestures and communicate well with gestures. Their motor and self-care skills are usually fine. They just have a language delay. Currently, there is no definitive explanation for the cause of SLI. We are generally looking at a genetic basis and seeing that there tends to be probably a set of genes that when they come together, that they'll be able to identify those and be able to identify a risk of language impairment. But exactly no known cause has been identified. And there again, no identification of a language gene or a group of genes, but there is a familial nature, meaning that in a family's gene pool, when a certain set of genes comes together in one child, that the child has specific language impairment. In other children, the genes may not come together in the same way, so that is why not every child will have it, just certain children. Plomin and Dale in 2000 state that the theory of assortative mating, the tendency to mate with a like individual, may be relevant to SLI, and that cognitive and verbal behaviors are more likely to influence mate selection than other physical attributes. So what do we see in SLI? Semantic problems are the first indicator of SLI. This is where the child does not have a very large vocabulary or learning words quickly. A child should be putting 2 words together and have at least 50 words when they turn 24 months or 2 years old. They often have phonological problems, so their speech sound production is delayed, or they have not been able to produce sounds correctly. They also don't understand rules like adding the S for plurals or adding the ED for past tense. They will also have issues with pronouns, verbs, verb tense, and word order. Often because of the problems with their vocabulary and their production of sentences, they don't get the same types and quality of opportunities to socialize. These children will often be the ones who are over in the corner of the playground at recess because he doesn't know how to use language and he can't join in with what the other children are doing. After multiple times of this, the child often self-isolates. Then they don't get opportunities to practice those social skills, and we see a delay in social skills. This is a perfect example for the debate of which comes first, poor social skills or language. A lot of times, children with SLI get misdiagnosed with autism. We are going to talk about autism, and I'll give you some things later that separate the two. We are now finished with chapter 3, a definite long one, but hopefully you enjoyed learning about these different disorders that you will be working with.